What is the hardest surgery to perform, but also to recover from?
The hardest surgery to perform is to fix somebody else's mistakes.
Oh, your journey, your speed, your story. Welcome to Find Your Pace. Dr. Jonathon Glashow, welcome to Find Your Pace.
Thank you for having me.
Of course. I am really excited because you're the first surgeon on this podcast. I have had physical therapists and chiropractors on here, but it feels like you are the next step in what people could potentially go to if they're in that injury space. So it just feels very fitting that you're on here. I've wanted a surgeon on, but specifically an orthopedic surgeon in sports medicine, which is what you are. So to give some context to who you are an orthopedic surgeon specializing in sports medicine, knee and shoulder injuries. You've worked with elite athletes like the Philadelphia 76ers and New Jersey Devils with over 30 years in this field. I had to actually Google what those teams were. I know nothing. So it's for anyone who doesn't know, it's basketball and hockey. So just to clarify for my girlies here who might not know what that is. Today I want to talk about athlete injuries, overtraining, recovery mistakes. But before we dive deeper into that, I do just want to know why you chose to become an orthopedic surgeon.
So I always wanted to be a doctor. My dad was a doctor, not a sports orthopedic surgeon. And I love the science of medicine. And I feel I have a bit of an aptitude in science. And so I love the helping people and figuring it out sort of mechanism. And as I went through schooling, I befriended, or an upperclassman mentor befriended me, who was a sports medicine fellow after medical school graduation. I was at Cornell, and he took me under his wing and introduced me to facets of sports medicine, helping people, getting them back to sport. I was always athletic and active, and I found it fascinating and super rewarding to take somebody who was injured, whose life was really upset by that, and with really just defined methods, just turning that all around. I don't have a particular affinity working for sick people. I feel I do better with healthy people I can relate to, and helping them just gave me tremendous satisfaction. It's as simple as that.
I love that. Like you knew this was it.
It felt right. Yes.
When you were active growing up, what kind of like sports or anything were you doing?
I'm not this gifted athlete of the patients I take care of. So I'm not that. I grew up in New Jersey. I played competitive tennis, swimming, and water polo, but I was never at the level of the people I see at the professional college or other. I just wasn't, but I didn't mean I didn't enjoy it as much. I did, I know we're on a running podcast, and I think running is wonderful. And I tried it. I was never a great runner, but I've tried everything, but swimming, tennis were kind of my outlets, and downhill skiing.
Mm-hmm. Well, you work with a lot of high end athletes, but do you also work with like everyday people?
Most of my practice is everyday people, some of whom think they're high level athletes. But you mentioned football or basketball and hockey, but we see a lot of football players. We see a lot of women athletes, a lot of women soccer players in particular, and ballerinas and dancers. And so it's not confined to just combat sports like football and hockey. It's really all the sports, because a lot of these problems are pervasive, and a lot of these problems exist in all sports in different ways. And it's challenging, but it's also very rewarding. And I think the other aspect of my field right now is that I try to take advantage of the nuance of new technology. And the new technology, whether it be in stem cells or biologics or other, and the technology that's helped us in a more minimally invasive way fix problems that were never fixable before, are very gratifying. And now you're seeing athletes extend their careers. And without mentioning particular athletes, they're basketball players that play in their 40s. One patient of mine retired this year from the Toronto Raptors. He was 41.
Wow.
So you never saw that when I was a kid. And I can't help but think the advances of understanding nutrition, rest, structural things in surgery, biologics have all contributed to the extended life of a lot of the high level athletes. And to the same way, athletes of everyday endeavor.
What do you think the biggest lesson you've learned is or was from treating these high level athletes?
There are a lot of lessons I've learned, but I think one of the mantras that I try to teach to the students as I teach at NYU is that oftentimes less is more. And trying to change everything and make dramatic changes is often well-intentioned, but fraught with problems. Mm-hmm. So I think less is more. Define the problem, define the solution. Don't turn everybody into the same. Don't approach everybody the same way. Look specifically what's wrong. Less is more in approaching it.
I was just going to ask you, do you look at injuries and surgeries differently than other traditional orthopedic surgeons?
it's not fair of me to say that. I like to believe that. I think it's true. And I think when you take care of athletes, you have to understand with these athletes who train and play a professional sport, that's their life. You come to this office, I go to my office, and they spend their days and weeks and months and years focused on training. So their bodies are going to react differently. Their normal is different than our normal. I'll give you an example that's not orthopedic. I got to participate with the NBA. Their hearts, by any measure from a traditional cardiologist, which I'm not, is very different than your heart and mind. So if they went to a normal emergency room and got a cardiogram, a lot of them would say very abnormal. The athlete's heart is very different than the non-athlete's heart at that level. Similarly, their orthopedic parts are different. There are adaptive changes that happen in bodies as a result of this extreme amount of training that makes them a different human than the average person who doesn't train like that. So it happens in the heart, it happens in the orthopedic world. And if you're not familiar with that while taking care of an athlete, you might identify a problem or identify an issue as a problem when it's really an adaptive response. And I think that's an important difference that you have to have and understanding how to take care of athletes at that level, which only comes with time, experience, and knowledge.
Do you think that you have learned all of that more so in the field than you did when you were in school?
No question.
Okay.
There's a saying that you really don't learn what you study in medical school in real practice, and it changes. And to my point about technology, like, when I was training, there were no cell phones. So I'm old. But, the level of changes in cell phones from 2005 to now, look at that. That same amount of change exists in medicine. Now, not everybody embraces it. Some people do the same thing they've done for 30 years. But I think that's so wasteful and not taking advantage of what we've discovered, what we figured out that works versus not. And I think if you utilize the new technologies and new understandings, you're a lot better doctor. You can help your patients much more. And it's to the advantage of all of us.
So when you get a patient, is your goal with them, or do you look at them and you say, I want to get you back and better into the sport that you're in? Or is it, I just want you to be pain-free?
Well, what I do is I ask the patient what they want.
Okay.
And I go, what's your goal? And I don't bring my intake forms, but essentially what it says is like, why are you here? How can I help you? What's your goal? And I really ask, what's your goal? And obviously pain is a big motivator of why people come in, or a suspected injury that prevents them from doing what they want to do. But what I try to present, especially in these young athletes, there's a rash of injuries this time of year in young athletes who are going to college who may injure their knee or shoulder and then have to get back in the game. Either they're on a scholarship or they're planning to play fall ball. And all of a sudden over the summer in training, they get hurt. And besides the physical aspect of that, there's the mental and somewhat depressive aspect of, wait, I trained all these months or years and you're 17 years old. I'm supposed to go to college sport or last year high school sport. Now I'm out. So I try to explain to them, we'll fix your structural problem and I'll teach you ways through what I know and through my people that I've surrounded myself, the training, strength and conditioning, physical therapy staff, to make you better than you were before and more resilient than you were before. So, hey, we're going to fix you, but not only fix you to put you back to where you were the day before the injury, we're going to make you better than you were and more resistant and more protected than other. And I think that gives folks, young people, all age people, the idea that, hey, there's some benefit to my injury in a sort of hidden way, that I'm going to be better than I was before. And so I try to impart that with them to give them the positive attitude that things should be better than it was. And maybe this wasn't all just for naught. I'll be better coming out. Long-winded explanation, but I really believe in that.
No. I mean, that makes sense. That's nice to hear. It's nice to hear that you're listening to what they want and then working together to make sure that, like, if it's that they want to get back and better into whatever that sport is, like, you're going to do your best with you and your team to get them there.
Exactly.
Yeah. What is the hardest surgery to perform, but also to recover from?
The hardest surgery to perform is to fix somebody else's mistakes.
Oh.
That's the hardest.
Okay.
Because you never know what you're going to get into. And it's very unpredictable, and patient expectations are very high. And there are a lot of factors that are uncontrollable when I take over a case that was initially operated on by somebody else. In general. Now, not all of them that way, of course. And then the other thing that's often really hard is a really bad trauma. Like we had a case of a young person who was in a bad ATV accident in Brazil, blew apart their knee. And it was in multiple pieces, and the initial treatment wasn't ideal. And things like that, where severe trauma with early neglect makes it the most challenging. But sometimes we get lucky, and if patients are really astute in their buy-in and they're healthy and do all the other things, there's great potential to resolve that. But those are the more challenging ones: previous surgery and massive trauma. Those are the hardest.
I watch a lot of Grey's Anatomy, so that
You do.
makes a lot of sense. I am a Grey's Anatomy surgeon in my brain. In my brain, I am. But also, okay, so what about recovery? Like, what is the hardest injury that people get that is the hardest to recover from?
So in my world, because it may be different for different subspecialists, but I'm a sports medicine knee and shoulder surgeon. So one of the hardest things to recover from in the knee is a multi-ligament injury knee. So in other words, the knee has 4 big ligaments. Everybody knows the ACL. Some people know the PCL, medial and lateral collateral. When you would injure 3 or 4 of those at a time, the knee dislocates. It's fraught with problems. It's a slow recovery because the rehab for one injury is not in concert with the rehab for the other injury. For instance, when you injure your ACL, you want to start moving right away. When you injure some meniscus, along with the ACL, you don't want to move too much because it may hurt the meniscus but benefit the ACL. So you sort of have to thread the needle on the recovery part. So again, big trauma, multi-ligament, multi-structured injuries are the hardest. Isolated injuries are much easier. Simple ACL, simple MCL, and back to shoulder or to shoulder, simple shoulder dislocations, fairly straightforward. Shoulder dislocation that has a bone injury as well, much more problematic. But we talk about recovery, and it's not just the surgical part or the physical therapy part. As I think we talk about, there's things like rest, nutrition, and all the peripherals that were seemingly ignored for decades that are now becoming, I think, almost in the forefront of people's eye as to what else can I do to help myself.
Mm-hmm. It's almost like people forgot that, like, one, in order for humans to live, we need to eat, we need to sleep, we need to hydrate. So it's like, why are we not thinking about those things when it also comes to being an athlete and being healthy? It's like, thankfully, it's come full circle that now people are actually hopefully paying a little bit more attention to what they're putting into their bodies in their recovery. But I do want to lean into injuries. So you deal with some pretty big injuries, but specifically we just talked about like knee and shoulder and ACL. So let's start with ACLs. So ACL tears specifically, why do they happen and why are they more common for women and runners? If that's an accurate statement.
Well, so it's interesting. ACLs happen more frequently in women than in men. That's a known fact. One of the reasons for that is the anatomy, because of the way the knee is in what we call a valgus or knock-kneed attitude in women, because women's pelvises are typically wider and their knees are formed at an angle called valgus, and that puts more stress on the ACL. Women who are of childbearing age who go through changes in their hormonal cycles make their ligaments more lax and more vulnerable at certain times of the month versus other times of the month. And I don't know that it's certain that it's really predisposed to runners. I don't see runners unless they misrun who tear their ACLs, but women tear their ACLs more than men. And we can talk about how to prevent that, et cetera. But most ACL tears happen from trauma. Skiing, for instance, is a common way that a lot of women that I see hurt their ACLs. And again, they're more vulnerable because of their anatomy. Just normal female anatomy is not exactly the same as male anatomy. And hormonal changes, as we just said, makes ligaments more vulnerable. But I think those are the 2 reasons we see it more in women. And I think that women's ligaments in general are looser than guys. Now, there are several guys who are looser than women, but if you took, broad strokes, the women's tendencies would be more laxity than men's tendencies. Does that answer it? Or
Yeah. Well, why do they? I guess is it mostly just like trauma, like something that like
it's a trauma.
Okay.
So you tear their ACL like when I see it in female soccer players. We see a lot of the professional women's soccer players, and the typical way that happens is the foot gets fixed on the ground and they twist their body over. Either they're being hit by somebody else or they just torque and turn, but their foot is fixed and it rotates the knee. And the knee is not a good joint to rotate. The shoulder is a great joint to rotate, but the knee has got 4 ligaments. It's supposed to be planted. It can bend and straighten very well, wobble side to side, but it doesn't rotate well. When you rotate it, it breaks. And one of the first things that break when you rotate it is the ACL. And it's a big injury because it's one of the center structures. So that happens on turf with cleats. We always say never wear cleats on turf because there's no motion in your foot.
Yeah.
So if you have a little motion in your foot, it could save you.
Because it grips.
So you don't want that. You want to have some play in the foot. So some of the torsional play is released by the foot and not taken up by the knee.
So it's almost like most runners, if they had an ACL tear, they were doing something funky because we're not wearing cleats. Some, like maybe they got knocked down or hit by a car, which is really
God
dramatic.
forbid.
But
Yes.
um,
Running
or they took just a quick turn, right? Like they just decided to like cut across the street last minute or something. But like it would have to be like pretty dramatic.
I agree. I think it's unusual to see a runner who's running without mishap to tear their ACL. But
Okay.
to your point, their injuries happen all the time. And maybe if you're running in a race or in a crowd and somebody pushes you and your foot gets caught and twisted, that's a plausible mechanism. But running doesn't in and of itself predispose to tearing your ACL. And it doesn't happen. It doesn't wear out. People say, does the ACL wear out? It's part of your body. It's alive. As long as you're resting, giving it nutrition, it continues to get stronger as it sees more stress. It breaks when it has a sudden moment of twist and force to it that exceeds the ability of the ligament to resist. And that's when it snaps. That's why you see the football player gets hit on the outside of their knee and the knee goes inward, it snaps. And that's exactly what happens. Or a runner gets hit by a bike or another runner.
Yeah.
That's how it could happen running.
Now, this might be a dumb question. Besides the obvious, is there a way to prevent ACL tears besides like getting into an accident or something?
It's a very good question. And that question's been asked and studied for decades. And the simple answer is, in my opinion, you cannot eliminate all ACL tears. But there are several things we can do, and particularly in women's health, that can reduce the likelihood of getting an ACL tear. And this has been studied and there's been published in numerous journals that if we can teach gals more than guys, but both, how to jump and land more effectively. If you land with knocked knees, you're much more likely to tear your ACL. So two things: jump mechanics, landing mechanics, and strength. Those things done correctly and taught correctly repetitively as incorporated into a workout will significantly reduce the incidence of ACL tears if trauma were to happen. Yes, meaningful, worth doing.
So like plyometrics.
Plyometrics, landing patterns, somebody who's trained in ACL prevention mechanics. And again, we talked about women's incidence being higher, particularly with hormonal changes, younger women. It's worth doing. And the average guy playing football, maybe it doesn't make as much difference, but women benefit immensely from education and training, strength and conditioning, and landing mechanic jumping patterns. Yes.
Okay. Last question on ACL specifically. If somebody did tear it, I'm assuming you have to get surgery to fix it. What does recovery look like for that?
That's a good question. And I smile because, ACL tears and fixing the ACL isn't just so routine anymore. To answer your question, you don't have to fix your ACL. But I always ask, here's what you're going to give up if you don't have an ACL. And if you look at the literature and you look at what we know about the natural history of the problem, if you don't restore the stability to the knee, and you're young and you're active, the knee will continue to degrade by becoming looser. The secondary restraints, meaning the other ligaments, will be stretched out. And more importantly, almost, the meniscus cartilage, which is that little rubber disc that sits between the bones, will very likely tear within a year or two of not fixing your ACL. And without that protective meniscus, the hard cartilage, which you can think of as that white shiny stuff that coats the end of the bone that you see when you eat a turkey leg chicken, that starts getting degraded. Now you took a knee from a simple ACL to arthritis, and that can happen in as quick as 5 years. And that's what we really try to prevent. So we fix most ACLs in young and active people. And frankly, we fix a lot of ACLs in middle to even older patients. But fixing the ACL used to be a tradition in which we would take another piece of tissue, not the ACL that was in there, and replace the ACL with something else. The traditional being that either hamstring tendon or patella tendon. But it was about 5 years ago, we started working on the BEAR concept, which is a bridge-enhanced anterior cruciate restoration repair, which in essence means instead of throwing out the ACL when it's fixable, in other words, if it's just torn off in one piece, we fix the ACL. We fix your own ACL and put it back. Rather than cutting it out, taking your patella tendon or hamstring tendon or an allograft, meaning cadaver part, instead of doing that, we take your own and fix it. And we've had wonderful results. I was on the Zoom call this morning with a Paris FC professional soccer player who came over from Europe, as they don't allow it in Europe, who's ready to return to play with her ACL repaired rather than reconstructed. So what I'd like to share with your folk who listen is there are all kinds of ACL tears. They're not all the same. And some, I don't think all, but some I think are certainly amenable to attempted repair, which is a less traumatic way to restore the function of the ACL without disrupting your other parts or putting in a cadaver piece, much less invasive surgery. And in my hands and hands of others who are experienced, can be a very effective way to treat it.
That's really fascinating.
It's also encouraging for athletes. Yes, I agree.
I mean, I don't know much, and I hope I never, ever, ever have to have anything with my ACL, but I always just assumed that you go back in and you just sew it back together. It just snaps and put it back together. I didn't know that you had that was what the process was. And now I'm assuming you're not the only one that's doing this, like what you call it, a bear tech.
So BEAR is this acronym
Okay.
that stands for Bridge Enhanced ACL, or Intercruciate Ligament Restoration. I'm not the only one, but I was the first one in the country who did it. And it was, and I'll tell you this story. If I think I can share this story.
So let us know later if we have to cut it
No,
out.
no, I don't think it will. But so we've talked about it before, so I'm very proud of it. So the concept is to get your body to heal this tissue rather than cutting it out. And especially attractive to me in younger people who the more invasive surgeries, especially when the body's still growing, is very disruptive. And it was about 5 years ago, and I got a call from another medical professional whose son tore their ACL. It was referred to me by a friend, something or other. And they were going to Boston, where I trained at Harvard Boston Children's. And I used to do these reconstructive ACLs in training. And they asked me for my advice. And I said, I've been repairing some ACLs even before this BEAR concept, but there seems to be a bit of a game changer. One of the scientist doctors at Boston Children's came up with this technique of installing a collagen graft or something that helps your native ligament heal itself. And so they agreed. I said, listen, the worst comes to worst, it won't work. And you burnt no bridges. You can go back to Boston and have this very invasive open surgery, and it'll likely work, but it has a lot of negative side effects. So they agreed, and we did this surgery, I guess in October of 21. And I repaired it, like you mentioned. I sutured it back together. I did some other tricks inside, which are too technical to go into now, and used this BEAR implant, which helps it heal. This kid now is a senior in high school, and he's the #1 lacrosse player in the country.
Wow.
So I felt very, I don't know, blessed, or I maybe feel really good to participate in this young person's care. I feel, I don't want to say changed his life, but I think in some ways we did. I think we enabled him to go back to his sport better with a minimal procedure on his knee. And so it works in the right hands for the right cases. It's not applicable to everybody. Certain tears you can't repair, in my opinion. Other doctors may tell you different, but I think it's a great tool to have and something we should keep in mind. Again, it goes back to my philosophy that less is more. Mm-hmm. And in those cases where you can get away with less, it's very attractive, especially for young athletes. I think that was too long an answer for your question, but I thought it was worth sharing.
No, I appreciate that. That's also really cool. It's cool to see your face light up of like telling the story of where he is now.
Yeah, really
proud. That's really cool. You should be proud. You absolutely should be proud. Pat yourself on the back, King. Okay, let's go into some knee pain that's not ACL specific, like runner's knee and jumper's knee, because it feels like there's all these different knee issues. How can they be avoided? But if someone gets them, how do you bounce back, or how do you come back from things like runner's knee and jumper's knee?
So runner's knee and jumper's knee usually refer to what we call anterior or frontal knee pain in the front of your knee. And a lot of times that pain is due to a tendinitis or inflammation of the tendon. And when runners feel the tendon that attaches to the lower part of the kneecap, that's jumper's knee, and maybe runner's knee is similar in that regard, but I think runner's knee is less specific in the sort of nomenclature. And it's interesting, that's a very different problem than problems of meniscus, cartilage, ACL. And that's usually pain on the tendon. And I think it's really good that you bring this up, because tendon health and muscle health and tendon training and muscle training are very different, and they require very different programs. And I think what gets neglected, maybe in runners, certainly a lot of the athletes, is tendon health. We just did this big study with the NBA, because a lot of the NBA players you may hear about have ruptured tendons like Achilles and others recently. And we find that this jumper's knee is a condition in which the knee tendon is very inflamed because you're not stressing the tendons. You do what's called junk loading. A little light jumping or persistent running loads the tendon a little bit, but never provides enough stimulus for it to get stronger. So there are a few tricks, one of which is something called isometric holds, which your physical therapist may have mentioned on their program here, or maybe the physical therapist listening know about, that you can do things where the leg is placed under resistance. Isometrically means isometric, same length, under static position with high resistance. That's the way to get tendons to get stronger, called isometric holds at different angles for different lengths of time. So people who have runner's knee or jumper's knee need to focus on tendon health. And the exercise component of it is obviously stretching, which I'm sure your professionals who came on before talked about. What I'd like to add is the isometric holds for strengthening the tendons, combined with collagen loading. So we're a big believer in using every facet possible to help people get better. So when you combine 15 to 20 grams of collagen with some vitamin C, 1,000 milligrams, ahead of a workout, that collagen gets imbibed into the tendon when you load it and makes it stronger. I know it sounds kind of hokey, but it's really true, and there's science to back it up. Keith Barr, a tendon physiologist we work with at UC Santa Barbara, or UC Davis, I think, has done a lot of the pioneering studies on that. So tendon health, you can strengthen your muscle by doing, resistance training, getting really strong, but those kind of training mechanisms or exercises may not really strengthen the tendon. So people with anterior knee pain should focus on a tendon health program. Vitamin C with collagen, 15 grams seems to be the threshold number, and isometric holds. So it's something that I think would benefit a lot of folks, because I often get that, and it was wonderful for me doing isometric holds. Mm-hmm. But it doesn't seem like you're doing anything, but you're just standing there, but you're doing a lot for tendon health.
That's really, it's funny that you bring this up. I was just talking to Nicole about this. I just started doing PT for my Achilles, but with a different PT. But one of the physical therapists that I brought on talked about a lot about tendons and how to strengthen it, and like tendons respond really well to load is I think a big thing that he said. But
He's
the
right.
PT that I'm going to is we're doing isometric holds, but we're doing weighted, and we're building up to about 3 times my body weight, because he says that, and I could be completely misquoting this, he said a lot of science to me, but basically I know that running is a single leg sport. I talk about that all the time, but something that didn't click to me until he said it was when you're running, your body, your leg or your tendons are experiencing about 3 times the amount of weight in related to force on that tendon. So we need to build your body and your Achilles to be able to hold or sustain or whatever the force of about 3 times your body weight. So I'm doing isometric holds, but with like 300 pounds, and it's on a barbell and I can't really lift it, but I'm trying to essentially. So it's really fascinating that you said that, because I'm personally learning a lot about this, and a lot of the physical therapists that I brought on have also said that. But I've been so in my head about Achilles that I wasn't even thinking about knee.
Yeah. Well,
like,
tendons, the tendon that's in the Achilles has the same microstructure principally as the tendon in the front of your knee. And that's a big source of knee pain. And it seems to be a bigger source of knee pain in women runners than men runners. Again, because the angle of the quadriceps attachment, it's often called the Q angle, is higher in women than in men. So that tendon gets stressed more. I think the message I think is important to get across: training for muscles are different than training for tendons. And you reinforcing this iso hold concept, I think, is really important. Mm-hmm. The other thing we talk about is blood flow restriction therapy. Have your physical therapist talked about that? I want to bore your audience.
Wait.
BFR,
okay.
Blood flow restriction. So this concept of blood flow restriction is the concept of strengthening structures under ischemic load. In English, that means you have a blood pressure cuff, for instance, around your arms or legs. Let's talk about legs. And you cut off between 60 and 80% of the blood flow to that part of the body and exercise through it. It makes it much harder. So you don't need to have the same amount of weight to get the same result. Plus, when the muscle is exposed to lower blood flow, it produces elements of growth factors that are unseen without being in ischemia. And those growth factors really stimulate muscle and tendon health more significantly than without it. So it's a cheater thing. We've been doing it in professional sports for over 10 years. But interestingly, and I'm all full of these useless anecdotes, it really started 35 or so years ago in San Antonio, Texas, with amputees. And they found that in amputees, that blood flow restriction helped with growth factors and healing and muscle rebuilding. So it's not a new concept. It's been fine-tuned to pro sports and other sports with mechanisms and delineation of how much, how long, what mantra, et cetera. But the concept of cutting off some blood flow, exercising through it, has proven exceptionally beneficial for muscle and tendon health.
Wow. Wait, that's really fascinating. So if,
BFR, yes.
let's say someone wanted to do BFR, do they need to be doing this under the guidance of like a physical therapist?
Not all physical therapists are certified in BFR. You have to take, there's some medical contraindications. For instance, somebody has had a blood clot or someone has a blood dyscrasia, blood ailment in their blood. They shouldn't have BFR. But for healthy folks, healthy athletes, it's a wonderful way. I personally do it at least once a week. And I found it extremely rewarding and productive in building strength.
Interesting.
And so imagine this. So you want to squat, some guys or gals, their goal is to squat 300 pounds or just pick a number, and you're light. You want to squat, you're doing these isometric holds. If you put these cuffs on, you don't have to put the 300 pounds on your back. You can do 100 pounds on your back with the same result, but don't load the joints. But you get the same benefit to the muscles and tendons with less weight without the downside of irritating the joints with all that weight. That's in essence an oversimplification, but accurate description.
I'm going to ask my PTs about this.
You should. Ask them if they're certified in BFR training, not to say that they're not, but you can buy certain cuffs online, but there are courses about BFR training. And if you learn the nuance of it, it's extremely useful. We use it in almost all the return to play regimens for all the professional athletes that we see.
Yeah, that's really
cool.
And
all the pro teams use it. Yeah.
And if pro teams are doing it, they're doing something right. You know, we can take some lessons from them.
Exactly.
Well, I guess just to kind of round everything kind of together, because what I'm understanding is that we really need to be focusing on tendon and ligament health, but also I would say bone health as well. But how do you protect your knees? I guess like the simplest way, how do you protect your knees over years and decades of training?
Yeah, that's a loaded question, I guess, right? So I think several things. I got to get this out there because people always ask me, is running going to give me arthritis? And you didn't really ask me that, but you kind of did. So I'm going to say running in and of itself does not give arthritis. But people who have injuries to their knees that run through pain and symptoms accelerate the rate at which the arthritis progresses. In other words,
I was going to ask you that. Should we be running through these injuries? No, this is great.
I'm not being specific here, so I don't want everybody listening or potentially listening to just take this to apply to them. I'm just talking in broad strokes. If you have healthy knees and you continue to load them and you get stronger, your cartilage actually becomes more resilient by running and loading it. The body has this useful kind of rule that if you load it, it responds to that load and gets stronger. It's different than driving a car. The tire's going to wear out in X thousands of miles. The body's alive. And as long as you give it the nutrients and direction and training it needs, it actually gets stronger with load as opposed to a car or mechanical structure, which necessarily weakens with time. So if you don't have injuries and you maintain strength, you're much less likely to get injured. One of the biggest shock absorbers, and you touched on this point earlier, that when you run, the force across your joint is probably between 5 and 7 or 5 and 10 times your body weight. The biggest shock absorber in your low extremity is the quad. The stronger your quad is, the more protected you are. But to complete the envelope, the tendon has to be strong too. We briefly talked about that. So one of the biggest protectors is strength training, getting strong. Use BFR to get strong, take the collagen and get your tendon strong, get the muscles strong. They absorb the shock, they absorb the load across your knee. And then don't overtrain because your body needs time to recover. And one thing we got to get in is vitamin D. One of the bigger causes I see of bone pain or musculoskeletal pain are patients who are low on vitamin D. 40 to 50% of Americans are low on vitamin D. And vitamin D is a necessary element for bone health and bone production and ligament and tendon health. So the body constantly absorbs bone and produces bone. There are osteoclasts that absorb the bone and osteoblasts that produce it. If the element of vitamin D isn't present, you can't rebuild. The body resorbs, but it doesn't rebuild. And blood tests for athletes, like we started our conversation with earlier, athletes are different than sedentary people. And everybody listening is probably an athlete. So your vitamin D level should be over 50. I think it should be between 60 and 80. Most internists or most Quest labs, and I'll get in trouble for saying this, they say over 30 is fine. Well, it's not really fine if you're running 40 miles a week. It's fine if you're, walking to McDonald's maybe, but it's not really fine if you're loading. So one of the easiest things, and we manage vitamin D in all the professional athletes, because if you're low, it's an easy way to take that variable out of the equation of trouble. So get your vitamin D high. So vitamin D3 is typically what you take, but some people don't absorb it. So their doctors could recommend D2, which is a variant that sometimes is easier for others to absorb. You have to have fat in your system to absorb it, but that's one way to keep your bones healthy. If you're low on vitamin D and you run, and we see this, you get a stress fracture. In a stress fracture, there are only two animals, I should say, or maybe not say, that get stress fractures. One's the human, which we're a human animal. Yeah. And you know what the other animal that gets stress fracture is? It's actually interesting. It's a racehorse. And do you know why likely? Because humans are driving racehorses to do too much.
Yeah.
Because the natural, in the wild, mammals know that when you do too much, you rest. And you eat spinach on the run there in the forest and you get some vitamin D. But humans push themselves. They don't get enough vitamin D. They continue running and they get stress fractures, and horses too. But nobody else gets stress fractures that I know of. That's my understanding. So if you take adequate vitamin D, and again, athletes monitor it, we should monitor it, I monitor it. I think it's a good way. And even before the stress fractures, you can get that shin splint type pain that a lot of runners feel. And oftentimes I've seen this in runners that it's unexplained. X-rays are normal. Sometimes MRIs show stress reactions. Sometimes they don't. They take vitamin D and all of a sudden a month later they go, my pain's better. So it's not this magic dust. And it doesn't cure everybody, but it's something we should think about with active people who don't monitor it or who are potentially low. That's all.
I'm writing this down in my brain. Collagen, vitamin C, vitamin D. I have a whole list of shopping I need to do after this. But okay, no, I like that. I kind of want to touch a little bit on shoulder injuries. I know obviously most of the people listening are probably runners, but that doesn't mean that they don't work out or triathletes or whatever. Shoulder injuries. And I have to just plug really quickly because I stalked your Instagram for a little bit. And I really do want to encourage people to look at your Instagram. I don't know who's the brains behind it, but truly good work, because I watched a video of you talk about just specifically exercises in the gym. And there's one video, and this brings me back, and I really want to touch on this quickly, is you touched on a chest press with a barbell versus a dumbbell. And one fact that you don't know about me is when I was 19, I got certified to be a personal trainer, and then I was a trainer for about 10 years. And you don't know what you don't know. But I grew up with a dad that trains the old traditional way of you just want to be buff, you just want to push weight, you're doing all the old school just, workouts and stuff. And this man has probably had every single injury, but he's also the most resilient man. He's done full Ironman. He will get any surgery and any procedure and come back better than ever. So that is my idol. He is the person I look up to. But specifically shoulder injuries, I figured out that he was doing just traditional barbell bench press. And I was like, get rid of the barbell, go for a dumbbell, and go for a little bit more of a neutral grip. Drop your elbows down. And you kind of said that in your video, and I'm just paraphrasing here, but I thought that was really funny. So I was like, okay, so I'm not wrong when I said that to my dad, and we joke about it. He's gotten better, but he still kind of defaults into that old way. But when it comes to shoulder injuries or rotator cuffs and things like that, what are some other, besides the barbell, because I just talked about that, what are some mistakes that people are making that they're not realizing that they're making?
It's a good question. And rotator cuff and shoulder problems, advance with age and use. And I think you highlighted on a couple, but I look at this as risk reward. How do I get the most benefit from training with the least risk? Because that's what it's like taking care of athletes. They want to push it and they want to be as strong and as flexible as possible. But how do we do that in the least risky way? And I think one thing that's not so obvious is that you really need to have a strong back to have strong shoulders. And most people, or most guys or young guys, tend to ignore the back so you don't see it unless you're looking in a reverse mirror. So everybody's pump and iron presses, press ups, push ups, blah, 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 biceps, triceps, which by the way, are just elbow exercises. And nobody focuses on their back. So one biomechanist, made this example. It's like shooting a cannon off a canoe. If the canoe's floating around and you shoot a cannon, the canoe moves, the cannon doesn't. And you need a stable back and a strong back in order to lift weights from your shoulder. So I tell athletes, get your back twice as strong as your front. You'll avoid most shoulder problems that are routine. You want to avoid injuries. You want to avoid specific traumas. But so, things like lat pull downs, reverse flies, rear delts, those things stabilize the shoulder so the rotator cuff doesn't have to work as hard. But most people ignore that. And you see them at the gym doing these, what I'm demonstrating, internal, external rotation of the shoulder. Yes, you can do that, but get your back strong first. So I think a common mistake and something we could supplement or advise people on is get your back strong before you work on your shoulder, before you do presses. And another caveat is the shoulder is really not designed to have the elbow go too far behind, like a really deep bench press, like my high school gym coach would say, the bar's got to touch your chest. That's how more athletes tear their pecs than help them with their shoulders. Mm-hmm. So I think restricted range of motion is wise, and getting your back really strong to get your shoulders and chest strong are the way to approach it.
I like that. I've never heard anyone say that when it comes to shoulders. Like I wouldn't think like, oh, I need to be working on my back. I would just think like restrict the movement and maybe go lighter. I would never think.
But think about this. Most folks or people in the city, they're all working, right? So you're on a computer, you're podcast, you're in front like this, you're not working your back. And a lot of our actions are in front of us. So we're using our front muscles to do things. We don't as often use the back. So you really want to stretch the front muscles and strengthen the back muscles. So big rubber band, reverse pull aparts, reverse flies, those things go a long way to help. In the in pitching world, in the baseball world, they all do rear delts. All the pitchers do constantly. They strengthen their upper back, their interscapular muscles, the muscles that go between the shoulder blades. Get those super strong. You'll avoid a lot of problems. And don't do dips or exercise like dips for the most part. And there's some people who probably love doing them, and that's okay, but it's risky. You can get triceps really strong without bringing your elbow behind your body like you do on a dip.
And we got some pretty big muscles in our backs too. It's like, why
the biggest?
Yeah. Why aren't we using them?
Well, we should.
Yeah. This episode of Find Your Pace is brought to you by Gorgie. We all know that middle of the day slump. You're tired. You feel like you can't think clearly anymore. Well, this is when you need to crack open a Gorgie. Gorgie is a healthy, better for you energy option in place of coffee, energy drinks, or pre-workout. It has 150 milligrams of green tea caffeine, 0 grams of sugar, and only 5 calories. It has L-theanine to support focus and clarity, biotin for hair, skin, and nail health. Hello. But most importantly, it is non-GMO project verified, so no nasty ingredients. Did I mention it was created by women for everyone? Yeah. You can purchase online at www.getgorgie.com, Amazon, or in-store at Target, Walmart, or Publix. So next time you hit that midday slump, crack open a Gorgie. Well, okay, I want to talk about a little bit about recovery and comeback. So when someone gets injured, are they going to be constantly battling that injury for the rest of their life if they choose to be or to continue training? Like, is it constantly going to be this nag of like, it'll come and go? Or is there a way that if someone gets injured once, like if they take the proper precautions and do all the things they need to do, that like that might never happen again, or they might never have to deal with it again?
So I would say that the goal is to have the latter, which is you have an injury, you fix it, and you go beyond that and you do protective exercises to prevent it from ever coming back. But that's not always possible. Certain injuries we can manage but never really fix. An example of that would be some bad cartilage damage in the knee due to an accident, and the cartilage is roughed up, that turkey leg, chicken leg analogy, there's some missing, and without extensive surgery, you're always going to have some issue there. So you have to manage it by getting the quad strong, et cetera. So that's one. But a lot of injuries that are focal or limited, we feel we can fix and prevent it from ever coming back and teach you the right exercises so that you're more resilient from it happening again. But sometimes in athletes, an example of like a hamstring pull, once you pull a hamstring, it's more likely to get torn again. And so you have to work really hard on exercise. Sometimes we use biologics like platelet-rich plasma, which you hear about in the news, PRP, or stem cells or mesenchymal cells, which we use often. Those kind of things can prevent the recurrence from happening as much, combined with exercise. I look at this globally. It's multifaceted. One thing usually doesn't work, but it's modifications, nutrition, rest, strength training, flexibility training, and maybe these biologics. So the combination of which we aim to prevent it from ever happening again. Certain things we can control that way. Others we just have to manage and accept that they may come back.
Okay, wait, because you just brought this up. So like peptides, PRP, stem cells, are they?
You said peptides.
Okay, sorry.
But that's okay.
So are they, okay, you can clarify,
No,
but
no.
are they, do they work, or is it just kind of like all hype?
No, they work.
Okay.
I think we have to take them individually. And in the medical world, we talk about platelet-rich plasma, which in fancy words is taking growth factors that are in your bloodstream. So how it works is we take some blood, variable amounts, and then throw away the red cells and the parts of the blood that we're not looking for and concentrate the growth factors, which happen to be in the plasma portion of the blood. We know if we capture the platelets, the plasma around those platelets are filled with great growth factors, and they circulate through our bodies all the time, but they circulate in a concentration that's not meaningful enough to affect a change. So what we do is simply use a centrifuge. We take blood, we can take 50 cc's, 80 cc's, 100 cc's, which is a relatively small volume, but looks like a lot when it's blood, and concentrate it down and take those growth factors and then put them in the exact area where we need things to work. And they messenger stem cells to come to the area. So we can think of PRP as the messenger cells. So we take this blood, we concentrate it down, and there are different systems out there, et cetera, and we put it in the knee tendon or somewhere where we want to create a healing response. And they signal the stem cells to get there. Or we can take your stem cells by going inside the bone marrow. Usually it sounds brutal, but it's really not. We do it all the time. And you take the stem cells out, and that's what those are the cells that we would attract by the PRP, but you take those out, you put it there, it's more productive in getting it to heal. So those are two things. They work. There's studies out there. There's published data that shows it works, helps arthritis pain, helps heal cartilage, helps heal tendons, ligaments, etc. That's been pretty well studied. I differentiate that from the peptides. And the word peptide, by the way, it sounds foreign, but it's really not. Insulin is a peptide. Mm-hmm. It's a short chain of amino acids, not big enough to be a protein. We call that a peptide. There are many types of peptides. Some have been around like insulin for, 100 years. Others are less well studied. Everybody asks me about BPC 157. It's not legal to prescribe it. There's no data on it, but I don't think it's harmful. It's in the gastric juices. It's been around for, the understanding of it has been around for decades. And I think we need to better define how to use it, where to use it, when to use it. But I think that's something that's being sorted out, but we really need to get some data. And we're, at NYU, we're trying to get on a study group with the compounding pharmacies and look at dose response and how it works and how well it works and how we need to use it. But I think that's the future. Yes.
Interesting. Okay. You kind of giggled when I said peptides, though. Is it like, do you get asked about peptides a lot now?
We do. We get asked every day about peptides. And legally, we can't prescribe it. And if you go to compounding pharmacies or you try to buy it, it says for experimental use only. So I can't recommend it. I follow the laws. And I think there's some future in it. And I think it's a really interesting concept to look at. But like anything else that you probably do, you want to have data behind it before you recommend it. And I think with the appropriate studies and with the appropriate, delving into how it works and how well people respond to it, we can get some answers, in a relatively short period of time. Mm-hmm. So I hope that happens.
I love that you follow the law. That's great.
Follow the rules.
Follow the rules.
Yes.
Okay. I have some questions from the listeners.
Okay.
I had posted that I was having an orthopedic surgeon on. And this first one is actually hilarious because I'm glad that I actually personally asked somebody who's a personal trainer recently or 2 days ago. And I said, hey, if you had this guy in front of you, what would be the first thing that you would ask? And he's like a super skeptic. And it brought it up because this was something that I hated when I was a trainer is most trainers, I would say specifically, hear people say, well, my ortho said I should never squat ever again. When in the reality is we squat every single day. You squatted to get on this seat. We squat if we're going to the bathroom, on the toilet. So it's like we squat all the time. Why do some orthos say you should never squat again?
So I'm not a psychiatrist. I'm just an orthopedic surgeon. So I can't tell you why somebody else says what they say. I don't think that's really sound advice to never squat again. I think squats are a wonderful exercise when done correctly. I think the real response is you should probably squat within the productive low risk range, which means never go super deep because the rewards are few and the risks are many. And I can't explain why somebody would say that. I think squatting and wall sits, which is a static squat, are wonderful training methods. And I do wall sit BFR all the time. And I think it's been fabulous. So I don't know why other people say what they do, but I would tell you that I think squats are a valuable tool and an exercise we espouse and recommend. We don't love going beyond 90 degrees for a lot of athletes. We don't love a lot of knee over toe because it irritates patellofemoral joint. But I think squats are great. And I can't tell you why somebody would say not to. One condition I imagine is if people have kneecap arthritis, it can potentially irritate if they go too deep. But otherwise, I don't know why somebody would say that. I don't think that's accurate, or I don't think that's wise.
It's just I used to hear it all the time, and
Really?
I'm like maybe when they're saying that that patient is not doing their due diligence to dig deeper. Like maybe I shouldn't squat 300 pounds. Like maybe that's what they're insinuating,
Maybe.
and they're just not. But I was like, that doesn't make any sense. We squat every single day.
I agree. And maybe it's that we see people do squats at the gym where they're like sitting their butts on their heels, and that's provocative. And
Yeah.
I don't think that's a great exercise for most of us. Some people get away with it. And I think maybe they meant that. But to say not to squat at all, I don't understand the rationale for that recommendation. So I'm sorry. Can't
No,
help you
don't.
on that.
Well, if you're not saying it, there's nothing for you to
I'm certainly
apologize,
not.
sir. Well, you just actually you mentioned arthritis actually a couple of times, and I knew I had this question here, so I want to ask you, how do you prevent arthritis, or how do you deal with it if you still want to work out and train?
I think training and exercise is a fix for a lot of the symptoms of arthritis. We talked a moment ago about keeping your quad super strong to act like a great shock absorber to take the load off the knee. I think once you have arthritis, and again, there's many types of arthritis, but in the common sense, most people talk about arthritis, and we talk about it now. I take it to mean the wearing of the hard cartilage that coats the end of the bone. Back to that analogy we've said a couple of times, where the end of that white shiny cartilage has been roughed up. Instead of being silky smooth, it's more like sandpaper. If you pound on that with running more, you advance those changes. You can still work out and should work out by keeping your quad really strong. Maybe you don't squat as deep. Maybe you don't use as heavy a load, but I think it's important to continue to work out. A bike, for instance, in that circumstance would be a great way to lubricate the joint, because when the joint flexes and extends, as you know from your training as a physical trainer, that imbibes joint fluid into the cartilage and makes it healthy. So I think stopping working out is a slow death. I don't think anybody should do that. I think they should work out smarter and more specific to their ailments and avoid certain things and emphasize others. But it's hard to give a general recommendation to everybody. But saying to stop working out because you have arthritis, I think is the opposite. I think you should train more, maybe swim more, maybe bike more flexibility, more core strength. I don't feel comfortable giving more specifics because I don't know exactly in this case what it is.
Agree. I anytime I've gotten injured for specifically like knee stuff, it's okay, maybe we take a break from running, but cycling, fine, swimming, great, like just keep moving, but we just need to alter it as like what you're doing. So no, that makes sense. This one is just kind of basic, I would say. Do I need surgery, or can most things heal naturally?
Well, cavemen died at 35 because we didn't have any surgery for other things. So when people say, I don't want surgery, I say, that's fine. But if you have a mechanical problem, you often need a mechanical solution. And while surgery is not for many or most injuries, a lot of times I feel it's the conservative approach because it gives the most predictable outcome. So for instance, if you have a broken bone and the pieces are separated and you don't fix it, you're not going to die. You can live, but surgery is a much more predictable way to have it heal correctly. So the questioner here says, can it heal naturally? I think a lot of things can, but the question is it going to heal correctly? And oftentimes, if the fracture, for instance, in this case or this example, if the pieces are together, it will heal naturally. Take the vitamin D that we talked about, immobilize it, whatever, you'll heal fine. But if those pieces are really separated or disconnected in the term of an ACL, it's not going to heal. And you can accept that and accept the consequences of it, but don't look at surgery as, I don't know, a weakness or a bad thing. I think in the right situation, it's a wonderful thing to restore the damaged part to a functional part or fix it, and life goes on. So if you took that kid with the young player with the ACL tear and you didn't fix it, they'd have arthritis in 5 years. But they can go along and say, hey, listen, I never had surgery, but their end result will be nowhere as good as than if they had the surgery done correctly and restored their anatomy to where they were before the injury. So surgery should be reserved for those conditions in which people cannot heal themselves with just rest and immobilization.
Yeah. I think as scary as surgeries can be, it's a blessing that we have that ability to have surgeons like yourself that could fix it and make it better than just not having that. Imagine if we just had no surgery. Oh my gosh.
Well, thank
Be
you.
awful.
And I agree. But but on the other hand, there's certain conditions which don't need surgery and maybe others would operate on that we should be, thoughtful about and careful about.
Can you give an example?
Well, if somebody has unexplained knee pain and there's no obvious mechanical issues, there may be times, and I'm not saying there are, but I think they are, that people say, oh, we'll just do an arthroscopy to look inside. I don't think that's a great routine use of surgery. I think if somebody has a big meniscus tear that's flipped and gets in the way and people are catching, that's a great use for surgery. But just to look inside because I'm not really sure what's going on, I'm going to have a look. I don't think that's a very good reason most of the time to want to do surgery.
And in all honesty, a surgeon wants to cut. Like, it's their job. Like, they're going to get paid to do it. So it's like.
Yes, but I would tell you this. I think some of my most grateful patients are those patients that I say, because I see second opinions, I go, something, you don't need surgery. Or at least I don't think you should do it now. I think you should do X, Y, Z first. And if you're not getting better after this, then maybe we should do it. So I love telling patients not to have surgery. But I'm also very frank with them when I really think they need it, like a fracture or a torn ligament or meniscus that really needs to be addressed. I think we're doing them a favor by recommending surgery. But you're right, surgeons are incentivized to operate. But I think there are a lot of very good surgeons who are honest and would tell you not to do surgery when surgery is not absolutely necessary.
Well, you are every patient's dream doctor because we don't know any of this, right? So we go to the hospital, we go to surgeons, and we're asking and hoping for the truth. And so we're thankful for surgeons and people like you that exist that will tell you the truth, even if that means you don't get anything from it. And
I get a lot from it. I feel good by doing the right thing and seeing people get better. And to me, that's tremendous satisfaction. It just is.
That's good. Well, good. You are a rare bird.
I don't know.
Yeah.
I'd like to think not, but thank you.
Do you recommend people get body scans like DEXA scans? Is that something that you would recommend people
I do it. I think it's great.
Okay.
I mean, so it's a piece of data. What is a DEXA scan? It's a way to look at bone density, body content. And I think it's a great way to understand how healthy and dense your bones are, how much body fat and lean muscle mass you have. And with that information, you can get a more directed program of what you need to improve. Do I need to improve density by doing more loading, by doing more running, to doing weight bearing stuff? Do I need to lose body fat because I'm out of the optimal range? And you could have too little body fat and change your metabolic world. So do I need more body fat? Do I need to do more strength training to increase my lean body muscle mass? I think that has a minimal amount of radiation, a DEXA body comp. And I think it gives a lot of valuable information, and I do it. And I think it's a wise choice to do.
I really want to do one.
Yeah,
it's
easy.
Really
it takes about
curious.
20 minutes. And I think it's a great way to see where you're at, and it gives you goals of what to strive for. Then you retest it in a year and see if you met your goals.
Okay.
Good
Well,
idea.
good. Yeah, I definitely want to do it.
Good idea.
Is it possible to regain bone density naturally?
Yes.
Okay.
Loading,
Oh, so like strength training.
strength training.
Oh,
Yes.
okay.
You can increase your bone density with loading and strength training. Now, people who are older or are too far off the curve, do they need, pharmaceutical help? Yes. But young people who are healthy, who load, get denser bones. Remember this thing called Wolff's Law. We talked a little bit about the bone responds to the load that it's exposed to. So bones are thin. So if you put a cast on, you see a kid who comes in and the pediatrician or pediatric ortho puts a cast on, their leg shrivels, their bones get weak. They start loading again, the bone gets strong. So
Oh.
it responds.
Yeah.
The body responds to the stresses it sees. The caveat to that is if you overload it too much, it breaks. But a measured loading increases strength. And again, it's sort of with tendons. Increasing load progressively, the tendons get stronger. The tendons break when they've seen no load for a while, and they get exposed to a overload. That's why the player who comes in the middle of playoffs, who hasn't played for 6 weeks, then ruptures their Achilles because the tendon hasn't been loaded progressively and in a measured way. I guess 10% a week load volume increase. And those are the people that get damaged. So load is very important. Measured load's important. Overload can break it.
Mm. That's a good way to put it. I was able to visualize what you were just saying, which is I've never, knock on wood, have broken a bone. So, but I know I've seen in Grey's Anatomy, someone comes in, they cut off their cast, and it is smaller, so it makes sense. Okay, I have one last listener question here. Running sneakers. I know you obviously don't run right now, but I'm assuming you would know maybe a little bit about this, or maybe you don't. Are there certain brands or styles that you recommend or tell people to avoid, / do you think sneakers truly matter?
I think sneakers truly matter. And I think it's very body specific. And so I'm not here to endorse one brand or another. I think the concepts are the following. People who have very flexible feet and very loose ligaments should have a more supportive shoe to control excessive motion. People who have very rigid feet should probably get more cushion or shock absorption. I think it's a general thing. I also think there are certain roles for orthotics in people whose feet are maybe a little bit on the outside of that bell curve. They're a little bit higher arched or lower arched. Maybe they need more help than the traditional shoe's going to have because their feet are a little bit different. So I wouldn't shy away from some sort of supportive orthotics if their feet are abnormal. But without recommending specific brands, whatever, I do think it makes a difference. I don't think it's the answer to everything, but I do think people with excess flexibility need more support. And I think people that are very rigid need more cushioning. And that's about the extent of my expertise. I'm not a foot and ankle specialist, but we talk about it all the time amongst each other. And that's kind of the overall consensus, if that helps.
I don't know exactly, I haven't gotten imaging done on my Achilles, but when I first injured it, one of the biggest recommendations that I got from physical therapists and then just word of mouth is to get a higher heel stack to limit how much flexion, I guess, or absorption my Achilles was getting. And that was just not something I ever thought about. I really didn't think, I know sneakers play an important role for sure, but I didn't think it really made that big of a difference. And making that switch definitely helped in the early stages of that injury. I think
that's very wise. And we call that like the Aquinas position, like a high heel for a shoe. So the high heel puts your foot in this plantar flex position. It takes the tension off the Achilles, as opposed to a rocker bottom shoe in which the heel drops below the toes. That puts a lot of strain or tension on the Achilles. So people who are healing from Achilles injuries or surgery, putting them in that Aquinas or high-heeled position is very valuable. So yes, it's a very smart, wise thing that your people recommended.
Smart. Okay, I want to end with a little rapid fire. Okay, there's only like 6 or 7 on this. So these are quick answers only.
Okay.
All right.
I'm not good at that, but I'll try.
It's okay. I mean, honestly, if you're like, I need to elaborate on this, you go for it. I'm not going to kick you out. Okay, most overrated recovery tool.
Cupping.
No, as I got it yesterday.
I don't see the value.
Okay.
I see it cause a lot of soft tissue stuff. I don't love it. Now, listen, I'm not saying it's not great for people who it's helped, and I think it's very individual. But in my world, I don't see it.
Okay.
There are a lot of other things that work better.
Most underrated recovery tool.
Sleep and nutrition.
Boring. Okay, besides those, give me something else. Give me like an
high volt DC stimulators that can sense injuries where the injury is in the body.
I'm sorry, what?
So you asked me to be specific as what else is underrated. I think that getting electrical stimulation through a high direct current on a system that has a brain that senses where the injuries aren't utilized by a lot of physical therapists or others. And without touting a specific brand, the NewFit brand has been very valuable to us in rehabbing tendon muscle injuries because the way the system is set up, it can actually sense where the area of damage is, and you can focus the electric current in that area. And I've had it worked on for me, and I've helped, many high level athletes with it. And I think it's a wonderful resource to utilize. So electrical stim the right way, DC current, high volt.
Got it.
Not all physical therapists use it.
My
Some do.
chiropractor does.
So there you go.
Yeah. It feels great. It feels weird, but
it helps.
Yeah.
Yeah.
Okay. That's what I was thinking more of like actual physical tools like that people could use on their bodies versus just sleep and nutrition.
Yeah, I know sleep and nutrition do sound boring, but I don't underestimate that. Without that, the other things don't work.
Yeah.
I think strength and tendon health is really important. And we kind of talked about that. There's no magic dust out there.
Mm-hmm.
There's no magic pill you're going to take that's going to work. I think you got to put all the pieces together the right way, and then it works.
Okay. Heat versus ice on injuries.
Interesting. Hot topic. An acute injury, what you're trying to do is block blood flow to prevent swelling. First 24 hours, it's ice to stop the damage, stop the blood from pouring into the area, which causes a lot of soreness and pain. After that, it's all about heat. Heat stimulates muscle growth, collagen growth. Heat brings in new blood supply, new cells, heats the new ice in some ways after the first 24 hours. Acute injury, you blow out your knee, you rupture your Achilles, you want to elevate and ice it for 24 hours, and then it's all about heat. It promotes blood vessel healing, it promotes collagen synthesis, it promotes protein synthesis. But the exception to that is when that acute inflammation occurs. When it first happens, ice the heck out of it without getting, frostbite or damage to the skin.
Interesting.
Yeah.
Did not know that.
Yeah.
Look at that. You learn something new every day. One exercise everyone should do.
Wall sits.
Now, what is one exercise people should stop doing?
Leg extensions.
Wow, you're gonna make a lot of
without isometric. With the exception of isometric holds. So in other words, if you lock your leg out at a fixed angle and hold it, that's excellent way to use the leg extension to build tendon health. But what I find a lot of runners or other athletes do, that constant arc puts a lot of shear across the anterior knee, and I think you do much better on a wall sit. Easy to do. You can do it anywhere. You're traveling. People say, oh, I travel so much, I don't have a gym. Do a wall sit. Do a single leg wall sit.
Oh, yeah.
That's it's hard. Nothing good is ever easy, right?
Yeah.
So do the wall sit in the right way. Keep your quads strong. Use the leg extension machine to do isometric holds, whereas you get the strength from the wall sit. That's my opinion.
Wall sits used to be punishment in sports growing up. We did something bad, our coach would make us go
Sorry
wall sit.
to bring out bad memories.
No, that's funny. Okay, knee sleeves, helpful or just aesthetic?
Helpful.
Okay.
I think the proprioceptive feel of a sleeve is often valuable. Never wear a knee sleeve on a plane. You can pool blood below and potentiate a blood clot.
Okay, well, you just said plain. What about compression sleeves?
A sleeve that goes from the toes to the hips, great on a plane. But if you're wearing a sleeve that's just around the knee, what happens is the blood pools below and can predispose you to a clot. Doesn't mean you wear a sleeve, you're going to get a clot. It's just not a good idea to do.
We've got the last one. Are you ready for this?
I'm going to try to be ready for it. Yeah.
What is the biggest myth in the fitness industry right now?
Wow. What is the biggest myth? I think there are a few myths. I love a cold plunge, but I don't think it retards aging.
Okay.
And I love it. And I have one at my house and I use it. And I think it's a great way to block inflammation. But to think that when you expose the body to really cool temperatures, you're going to live longer, I don't think that's true. I think one thing that's the opposite of that, I think this red light therapy has a lot of leg to it. And I take away the cupping and I take away some of the cold and I'd put in some more heat and sauna and red light. But, I'm not an all or none type person. I think different people respond differently. And I think some body types do like the cold, but I don't think it prevents aging. And I think there's a bit of a myth in that out there that I hear.
Yeah. I only like cold plunging when it does feel good on the body from time to time, but more so just the mental benefits. I feel like I can tackle anything.
I know.
Like you get out and you're like, oh, the hardest part of my day's over.
It's a great way. And I think there are some benefits to it. I just don't think it's the end all.
Yeah, I agree. Okay, well, I know what I'm leaving from this episode with is vitamin D. But, and maybe this is your answer, just the final question is, for anyone who's listening to this conversation right now, what would be the number one thing that they should take away from it?
I think the vitamin D is a very valuable one. I think focusing on strength and conditioning that both fixes or helps your muscles as well as your tendons, and everything's a bit of a balance. I think training can be overutilized and you can overtrain and get worse. So I think moderation, balance, look at all facets that go into training and healing that are not limited to just strength training. There's rest, there's nutrition, there's flexibility, and there are all the other peripherals that we just talked about. I don't think you can, but I think the vitamin D is really low-hanging fruit, easy to do, and helps a lot of people prevent injuries. So if their bones are stronger because they've taken the vitamin D in strength training, when they fall, they're not going to get injured the same way as somebody who doesn't. And I think continue to train at every age, because when you stop training, you start dying. So I would focus on training. It's good. Arthritis is not an excuse to stop training. It's an excuse to modify it to a certain way and help the arthritis, but don't stop.
I love that. I guess to just round it out, I would recommend that people follow you on Instagram. But is there anything else that you have like published or like that you would recommend for people to find more about you? Or
Joey, who's here, he's managed our social media. The thing about me is that I don't like to make these summary recommendations that apply to everybody, because I think us as humans are individuals, and I practice medicine that way, and I advise athletes that way. And what works for athlete A is not going to be the best for athlete B. So you want me, and I understand, to give an answer that's going to help everybody. I think the vitamin D is very legit, and I think the tendon health and the collagen is very legit. But I would recommend an exercise prescription that may be very different in athlete A versus athlete B. And I think maybe on the Instagrams that we do, we try to say, hey, if you have this problem, you should focus on this answer. And if you have that other problem, you should focus on the other treatment form. So it's hard for me to give you a summary recommendation, but what may be good for one person may be not so good for the other. So I'm sorry, I can't give you that exact, but we try on these Instagram posts to identify common problems and avoid certain things, or tell people to avoid certain things that get a lot of others in trouble, like bench pressing too deep gives them, shoulder pain or ruptures pec muscles.
Yeah. Well, I say that I recommend them going to your page, because who better to talk about these things than someone who is super experienced and knowledgeable in this world.
Thank you.
But thank you so much for your time today. I know you're a busy man. I hope you don't have any crazy surgeries today.
No,
but
not today,
I really
tomorrow.
Appreciate it.
But it was fun. I enjoyed the interaction, and it was fun. And I hope some people get help with it, and that makes it very gratifying.
That's what we're here for.
Great.
Thank you.
Pleasure.